Hi everyone, welcome to our module on spinal cord syndromes. So there are 7 spinal cord syndromes that you should know as a medical student, and we'll talk about each of these in this module today. First one is polio and a very related condition called Wernicke-Hoffmann disease, multiple sclerosis, ALS, there's anterior spinal artery occlusion, tabes dorsalis is a manifestation of syphilis, and then we'll talk about syringomyelia and subacute combined degeneration. So we'll start by talking about polio. Polio is caused by a virus, a single-stranded RNA virus, and you almost never see it anymore in the United States because it's prevented by vaccination. So polio has a very interesting history. Prior to the 1900s, polio was endemic in the United States, and almost every newborn baby was exposed. However, at that time, they had antibodies from their mother, so they had a very mild illness. In the early 1900s, as sanitation improved, there started to be less and less polio around, so babies didn't get exposed when they had those maternal antibodies. Thus, they grew up without exposure to polio, and then they got exposed when they were teenagers or young adults, and they would get very sick from the condition. Some of you may know that Franklin Roosevelt, who was president of the United States in the 1940s, had polio and was confined to a wheelchair by it. So polio results in destruction of the anterior horn cells of the gray matter, which I'm highlighting with my pen right now. And those are the lower motor neurons. So when you get destruction, you get lower motor neuron paralysis, which is a flaccid paralysis. The classic presentation that you should know for your boards is going to be an unvaccinated child, maybe a child from another country where vaccination isn't as common as in the United States. The baby will initially get a febrile illness, but then about 4 to 5 days later will start to develop neurosymptoms. There'll be weakness that's worse in the legs more than the arms, and it will be a flaccid weakness in the lower extremities, and that is what polio will look like. Wernicke-Hoffmann disease is very similar to polio, only it's not caused by a virus. It's a genetic condition that results in muscle atrophy. So in Wernicke-Hoffmann, babies have hypotonia and weakness, and one of the classic findings is to see tongue fasciculations on physical exam. It's sometimes called the floppy baby syndrome. The lesions in the spinal cord are identical to polio. It's also loss of the anterior motor horn, and these babies usually die within a few months. Multiple sclerosis is a condition I discuss in a separate module, but what you need to know regarding the spinal cord is that it is a white matter disease. It's a demyelinating condition. So what you'll see on spinal cord cross-sections will be random asymmetric lesions, maybe one here, maybe some in the back here in the posterior column. And then it characteristically follows this relapsing, remitting pattern. It usually affects young women, and they will have symptoms in one region of the body for a period of time that will go away and then come back in another region. And this also affects the cortex and the brainstem, not just the spinal cord. Next condition we're going to talk about is called amyotrophic lateral sclerosis, and this is a disease where, for reasons we don't completely understand, neurons begin to die. It's a combined upper motor, lower motor neuron disease. So let's look at this spinal cord cross-section on the right. In ALS, patients will lose their anterior horn cells, and this is what gives them the lower motor neuron symptoms. They also lose their cortical spinal tracts traveling here in the lateral white matter, and that gives them the upper motor neuron symptoms. Importantly, there are no sensory symptoms. So these patients will have upper motor neuron symptoms like spasticity and exaggerated reflexes, and they'll also have lower symptoms like wasting and fasciculations. Cranial nerves can be involved, and especially with regards to dysphagia, so patients with ALS will have progressive difficulty swallowing their food, and eventually many of them go on to need a feeding tube because they can't swallow. It's most common in 40 to 60-year-olds, and it's usually fatal in 3 to 5 years, and one of the common ways people die is aspiration pneumonia. So because they can no longer swallow from muscle weakness, they can't clear secretions in the back of their throat, and they end up aspirating those contents and getting pneumonia. There is one approved therapy for ALS. It's called riluzole, and it decreases glutamate release from neurons. This has been shown to increase ventilator-free survival by just a few months, so it's really not a very effective treatment for ALS, but it is the one drug that is FDA approved. You should know for your boards that there are some familial cases of ALS, and in some of these families, they have identified a zinc-copper superoxide dismutase deficiency. This is an enzyme that's a free radical scavenger, so when you're deficient in this enzyme, you get increased free radical damage to neurons, and that may be one of the mechanisms by which the neurons die in ALS. In the United States, ALS is usually called Lou Gehrig's disease, and this is a picture of Lou Gehrig. He was a baseball player in the 1930s. And it's hard for us to appreciate this in the modern era, but in the 1930s, baseball was followed by virtually everyone in the United States, or even people that didn't follow baseball knew a lot about it because it was so popular. And Lou Gehrig was an all-star. He held the Grand Slam record, and everybody considered him an excellent hitter. So when he developed ALS, his batting average started to decline because he just couldn't hit the ball, and then finally he was diagnosed with the condition, and then he died from it 2 years later. So if you meet people who grew up in the 1930s, they will always remember that ALS is the disease that took Lou Gehrig out of baseball. So the classic presentation that you should know for your boards is going to be about a 50-year-old patient because that's the median age. It'll be a slowly progressive course over a few months. They'll have arm weakness, they may have dysphagia to solids and liquids. Some of their muscles will be flaccid and some will be spastic because remember there's upper and lower motor neuron disease. And then importantly, there'll be no sensory symptoms. Next, let's talk about an anterior spinal artery occlusion. This is a form of stroke that involves the spinal cord. If you look at this drawing at the bottom right side of the screen, the anterior spinal artery sits here. So if there is occlusion of this vessel, this will cause ischemia of the spinal cord in all the anterior portions that I'm marking with my pen. What will be spared are the posterior columns back here because they have an alternative blood supply from the posterior spinal artery. This means that vibration and proprioception will remain intact, but all other sensations can be affected by an ASA occlusion. This presents with an acute onset. It's a form of stroke involving the spinal cord, and initially patients develop what's known as spinal shock. When the occlusion first occurs, there will be flaccid bilateral paralysis from loss of lower motor neurons at the spinal cord at the level of the lesion and all levels below the lesion. This is because of the sudden and abrupt decline in blood flow from the anterior spinal artery. Weeks later, however, other vessels will restore blood flow below the level of the lesion. What this will leave behind is a lower motor neuron defect only at the level of the lesion. Below the level of the lesion, there will be an upper motor neuron defect because of damage to the cortical spinal tract. So at those levels that are below the lesion, you will have hyperreflexia and spasticity. So ultimately, what you get if you have a spinal cord like this and the level of the lesion here is you have a lower motor neuron set of findings here. Everything below it will have upper motor neuron findings. This is what you'll see in someone who had an ASA occlusion and after several weeks have gone by so that the initial spinal shock has resolved. Next condition we're going to discuss is tabes dorsalis. So this is a manifestation of tertiary syphilis. So remember that syphilis has 3 phases to the infection. In the primary phase, you get a painless chancre. A few weeks later, you get the secondary phase, which is a rash, and then that resolves, and then several years later, you get tertiary manifestations of the disease, and one of the tertiary manifestations is tabes dorsalis. And in this problem, you get demyelination of the posterior columns. And remember, these columns are what carry the proprioception and vibration information up to your brain. You also lose the dorsal roots, which are coming in here and bringing sensory information into this level of the spinal cord. So what's going to happen is, number one, these patients are going to lose their ability to detect proprioception, and they're going to lose their balance and become ataxic. Also, because there's no sensory information coming in through those dorsal roots, they're going to lose their reflexes. The way you have a reflex is that sensory information comes into the spinal cord, synapses with the anterior horn, and goes back out. The reflexes will be lost in tabes dorsalis because of loss of this dorsal root of the spinal cord. So the classic presentation is going to be a patient who has other STDs. Maybe it'll even be an HIV patient. The patient will complain of difficulty walking. Maybe they'll have falls or an abnormal gait. They'll have completely normal strength in the arm and legs because motor function is not affected. They will have a positive Romberg test. Remember, the Romberg test tests the function of the posterior columns, and these patients have no proprioception. They'll often have a wide base gait. They can get fleeting and recurrent shooting pains. This is just another part of the condition that goes along with it. They won't have their ankle or knee reflexes because remember, like I said, you lose those dorsal roots of the spinal column. And then finally, they almost always have Argyll-Robertson pupils. These are pupils that are associated with neurosyphilis. They're pupils that are very small, and they don't react when you shine light in them, but they will react if you have the patient follow your finger in to test accommodation. Syringomyelia is a condition where a fluid-filled space develops in the spinal canal and damages the spinothalamic nerves that are crossing the center. Let's take a look down here at this picture of the spinal cord on the right. So this is the spinal canal right in the center that contains cerebrospinal fluid. And in syringomyelia, a large cyst develops around the spinal canal. So let's think about what the implications of that would be for the patient. You have spinothalamic fibers carrying pain and temperature information coming into the dorsal horn and synapsing. The second neurons then cross right in front of the spinal canal over to the other side to ascend. So when you damage that area, you will lose that pain and temperature information at the level of the syrinx, and that's what we call the cyst, a syrinx. You would also lose it on the other side because spinothalamic fibers are also coming in here and synapsing and sending nerves over to the other side. So you will lose bilaterally the pain and temperature information at the level of the spine where you have the syrinx. And this usually happens at about C8 to T1, so primarily the loss of pain and temperature sensation is in the arms and the hands. Although the primary effect is to lose pain and temperature, the syrinx can expand to affect the anterior horn and give muscle weakness. It can also expand to affect the lateral horn and lose sympathetic information to the face. That would cause a Horner syndrome. So let's look down here on the right. So a small syrinx might look like this and just take out pain and temperature fibers. But a large one could begin to damage some of these anterior horn cells right here to give lower motor neuron symptoms. And then an even larger one could start to damage the lateral horns, which are right here and are carrying sympathetic nerve fibers. So you can get muscle weakness and Horner syndrome along with syringomyelia. And one thing you should know that can help you to identify these cases in board questions is that many patients with syringomyelia also have a spine curve, so they have kyphoscoliosis. And for reasons we don't completely understand, this may obstruct CSF flow and lead to the creation of this cyst. So watch for a patient with an abnormal spine. They may have syringomyelia. So why do you get this? Well, you can get it from trauma. So if you have damage to the spinal cord, years later some patients develop syringomyelia for reasons we don't understand. And then it can be congenital. Syringomyelia is strongly associated with Chiari malformations of the cerebellum, and I talk about this in more detail in the module on neuroembryology. So let's talk about what the symptoms of syringomyelia would look like. First of all, it's important to know you get symptoms only at the level of the lesion. This isn't affecting the white matter tracts running up and down, so unlike other spinal cord syndromes, you won't get complete sensory or motor loss below the lesion. And since it usually affects C8 to T1, you're going to get primarily symptoms in the hands and back. So you want to watch for pinprick and temperature loss in those regions. The legs will usually be normal. Position and vibration are normal at all levels. And the way patients are going to experience temperature loss may be burns that are not felt, and the pain loss may be cuts that are not felt. Now, if it's a large syrinx, you may get those motor symptoms like I showed you before. And if it's very large, you may also get Horner syndrome. So the classic presentation is going to be a patient who has cuts and burns on their hands that weren't felt, and they've lost pinprick and temperature in the back, shoulders, and arms. And then remember that it may also include motor weakness or Horner syndrome if it's a very big lesion. Next, we're going to talk about subacute combined degeneration, or SCD, and this is a condition that happens when you have a B12 deficiency. And in subacute combined degeneration, you lose the posterior columns, which are back here, so these symptoms are going to be very similar to tabes dorsalis. But what's different from syphilis is that you also lose the lateral motor tracts here, so you get upper motor neuron symptoms. It's a slowly progressive condition. Patients present with weakness from the motor neuron loss and ataxia from loss of proprioception. And you may associate B12 deficiency with macrocytosis of red blood cells, but you should know that you can get this in absence of macrocytosis. So just because the red blood cells are normal doesn't mean the patient does not have subacute combined degeneration. The classic presentation is going to be a patient who has problems walking from the ataxia due to loss of proprioception. There'll be a positive Romberg. There'll be spastic paresis in the legs. The lower extremities will be hyperreflexic. And then you also have a positive Babinski. And all of these are signs of upper motor neuron damage. I often think of this as tabes dorsalis plus upper motor neuron damage because that's what it looks like. Next, let's talk about the Brown-Séquard syndrome, and the boards love to ask you about Brown-Séquard syndrome because it basically tests your knowledge of spinal neuroanatomy. In Brown-Séquard syndrome, you have a hemisection or damage to half of the spinal column, so you lose half of the spinal cord like what I'm drawing down here right now. This is classically caused by trauma, like a knife wound or a gunshot, but it can be caused by tumor. And what you lose is pain and temperature on the contralateral side to the lesion, and motor position and vibration on the ipsilateral side. So let's talk about that in a little more detail. You have spinothalamic fibers bringing in pain and temperature information here. The second neuron synapses and crosses over to the damaged side, so none of that information can get picked up and ascend in the spinal column. So you're going to completely lose pain and temperature on the opposite side of the body. On the affected side, proprioception and vibration cannot ascend in the posterior column because it's been damaged, so you lose position and vibration over here. In addition, the cortical spinal tracts are lost right here, so you lose motor function below the lesion. Let's talk about this in a little more detail because this can be confusing. On the opposite side of the body from the lesion, pain and temperature information in the spinothalamic tract wants to cross and ascend in the white matter on a damaged side, but it can't do that, so you lose pain and temperature on the opposite side of the body. On the side of the body where you have the lesion, the proprioception and vibration information cannot ascend in the posterior column here, therefore you lose proprioception and vibration. In addition, you lose the upper motor neuron innervation to the muscles below the lesion because you've lost the corticospinal tract. So I've summarized this at the bottom. No motor, proprioception, or vibration on the injured side. No pain or temperature on the contralateral side. Now, one special point, the level of the injury is a little bit different from all the levels below the injury. At the level of the injury, you have complete sensory loss, proprioception, vibration, pain, and temperature. And why does that happen? Well, let's look here. These proprioception vibration fibers are trying to enter the dorsal horn and go up the posterior column. They cannot do that. So at the level of the injury, you've lost vibration and proprioception. Pain and temperature information wants to enter the dorsal horn and synapse and ascend on the opposite side, and it cannot because that level is damaged. So you lose pain and temperature as well. Thus, at the level of the injury, you have complete sensory loss, pain, temperature, proprioception, and vibration. In addition, at the level of the injury, you have damage to the anterior horn cells, so you get lower motor neuron symptoms. Below the lesion, you will have upper motor neuron symptoms from loss of the corticospinal tract. Thus, what I've summarized at the bottom is what happens. No motor, proprioception, vibration, pain, or temperature on the affected side at the level of the lesion. This slide shows a picture that is often used to depict the neurologic findings in the Brown-Séquard syndrome. Remember that the weak side of the body is the side with the lesion. You will see upper motor neuron signs below the level of the lesion. Then there are basically three areas with different neurological findings. The first area is the level of the lesion, area 1. At this level only, you will see lower motor neuron signs and also loss of all sensation. And one special note about this level of the lesion, if it is above T1, you will also see loss of sympathetic nerve fibers, and this will lead to a Horner syndrome with a constricted pupil and eyelid droop on that side of the body. The second affected area is area 2. This is the ipsilateral side to the lesion shown here on the picture. At this level, you will have loss of motor fibers and loss of the posterior columns. And then finally, there is the third area, which is contralateral to the lesion shown over here on the picture. In this portion of the body, you will see loss of pain and temperature sensation. So the classic presentation is going to be someone with a prior trauma like a knife or a gunshot wound. At the level of the injury only, there will be no sensation on the affected side. On the side with the injury, there'll be spastic paresis below the lesion, there'll be a Babinski sign, and there'll be loss of vibration and proprioception. And on the opposite side of the body, there'll be loss of pain and temperature. Finally, let me discuss the cauda-equina syndrome. So the spinal cord ends at about L2, and this is called the conus medullaris. But the spinal nerves keep going beyond the end of the spinal cord, and that's called the cauda-equina, which means horse's tail because those nerve fibers look like the tail of a horse. The cauda-equina nerve roots supply motor innervation to the lower extremity, sensory information to the lower extremity, and they also innervate the pelvic floor and the sphincter muscles. So a cauda-equina syndrome occurs when you get compression of the cauda-equina, and this can happen if you have a massive vertebral disc rupture, or it can happen from trauma or tumor. So the classic presentation is severe low back pain and something called saddle anesthesia, and this picture over here on the right shows the area involved in saddle anesthesia. It's the area that would sit in the saddle. So patients won't have sensation over their buttocks in that area. They also lose the anocutaneous reflex. This is also sometimes called the anal wink. So when you touch the skin outside of the anal sphincter, you will see a contraction of that muscle. These patients can also have bowel and bladder dysfunction. And importantly, though, they will have a normal Babinski. So why is the Babinski normal? Well, the reason is because the nerves in the cauda-equina, although they're in the spinal canal, are technically peripheral nerves. They've exited the spinal cord. So you won't see upper motor neuron findings, you see lower motor neuron findings. Finally, a related syndrome to cauda-equina syndrome is conus medullaris syndrome. This is where you get compression of the conus medullaris, that end of the spinal cord. The signs and symptoms are very similar to cauda-equina syndrome, but a couple of symptoms that are more common in conus medullaris than cauda-equina are perianal anesthesia. So in conus medullaris, you may have loss of sensation only around the anus, but not the entire saddle area. And then also impotence is more common in patients with conus medullaris as opposed to cauda-equina. And that concludes our module on spinal cord syndromes.